Hi, this is Dr. Baksh here. Let's talk about pyloric stenosis today. Now, this is a small topic, but at the same time, a very important one in pediatrics. Now, pyloric stenosis, or it's properly called as infantile hypertrophic pyloric stenosis, simply HPS. It's basically hypertrophy of the pyloric sphincter, which causes narrowing of the pyloric canal. Now, it is the most common cause of gastric outlet obstruction in 2 to 12 weeks of age. It leads to progressive and projectile vomiting. Now, the prevalence, it's about 4 times more common in male babies as compared to females. Let's see the anatomy. As we can see, here's esophagus going into the stomach, and from the stomach into the duodenum, which is the first part of the small intestine. Now, the last part of the stomach, it's called the pylorus. It has two parts. The first part is called the pyloric antrum, which connects it to the body of the stomach, and the last part is the pyloric canal, which connects it to the duodenum. Now, around the pyloric canal, we have the pyloric sphincter. It's basically just a ring of smooth muscle cells around the pyloric canal. Now, it is innervated by sympathetic, it receives sympathetic innervation from celiac ganglion. Now, in pyloric stenosis, because of the hypertrophy, the pyloric canal becomes very narrow. It causes outlet obstruction. So all the contents in the stomach, there will be regurgitation and vomiting. Now, the cause is unclear. There are some points, but these are very low yield points. Like some say the hypertrophy is due to repeated contractions of the sphincter or due to poor neuronal innervation, and some say it's because of nitric oxide synthase deficiency, which causes decreased smooth muscle relaxation. Now, the risk factors or important associations. It is more common in firstborn and in male babies, or if there's a family history of pyloric stenosis before. If it's a preterm delivery, it has also a very strong association with the bottle feeding and also early exposure to macrolides, particularly before 2 weeks, and especially to erythromycin. Now, the clinical presentation, it is more commonly seen in 3 to 6 weeks old infant. Now, the baby will come with non-bilious projectile vomiting. A very high yield point is that the baby will be hungry post vomiting. Another very high yield point in examination is we may be able to feel a small mass in the right upper quadrant of abdomen, which is olive shaped. There may be peristaltic waves, but these are less common. There will also be dehydration depending upon the duration of the symptoms. So there could be a lethargic baby, tachycardia, decreased urine output, dry mucous membranes, depressed fontanelle, and even poor weight gain. Now, the diagnostic tests. It's very important to check the serum electrolytes because these patients may have hypochloremic metabolic alkalosis with paradoxical aciduria. We'll talk about this shortly. Now, ultrasound is very important. It is about 97 to 99% sensitive in pyloric stenosis. It will show the pyloric muscle thickness of more than 4 mm and pyloric canal length of more than 17 mm. In infants, this is normally less than 3 mm. We can also do an upper GI contrast study which will show a string sign due to the narrow pylorus, but this is not done because of increased risk of vomiting and aspiration. Okay, so now, like I was saying, in projectile vomiting, there is loss of stomach acid, loss of HCl, there is loss of sodium and potassium ions as well. So this causes hypokalemic metabolic alkalosis. Now, in order for the kidneys to compensate, it must get rid of bicarbonates, but it cannot secrete bicarbonate without chloride. Now, because of hypokalemia, it cannot get rid of bicarbonates. So, this bicarbonate will also cause more metabolic alkalosis. with hypovolemia in the body, the aldosterone gets activated. Because of increased aldosterone, the body reabsorbs sodium and water. Now, because of sodium and water retention, but this is done at the expense of potassium and hydrogen ions. This leads to paradoxical aciduria, as we can see here. Now, the treatment. The mainstay treatment is surgical, but before going to surgery, it is very important to make sure about fluid resuscitation and to correct the electrolyte imbalance. So once it is corrected, we can go forward with surgery, which is called pyloromyotomy, in which what we do is we just simply we make longitudinal splitting of the pyloric muscle. It is done by two techniques, laparoscopic and open techniques, and both techniques are okay. We can do endoscopic balloon dilatation as well, but this is not done because there is a risk of perforation and it's not as successful as pyloromyotomy. Okay, so let's look at post-op complications and prognosis. Now, post-op emesis is very common, but it resolves spontaneously, so it's nothing to worry about. The rest are very rare complications like wound infection, mucosal perforation, or incomplete myotomy. Now, the prognosis is excellent. The surgical treatment is about 100% successful, and the complications are very negligible. So that's it for today. If you liked the video, do give us a thumbs up and do share and subscribe. Bye bye.